Welcome to today's Explainer. We're looking at a huge shift in how we approach one of the most significant events in human life, childbirth. Just picture this. You walk into a medical appointment and instead of a provider just mechanically checking off boxes on a standard checklist, they actually sit down and want to understand you. I mean, the whole you. Your body, your history, your unique personality. Today, we're unpacking this deeply personalized approach, and we'll see how it stands in stark contrast to standard obstetric protocols.
To kick things off, we really need to ask a fundamental question. Is pregnancy a medical emergency just waiting to happen, or is it a natural process? Now, this isn't just semantics. This single question sits right at the heart of a massive philosophical divide in maternity care today. How your healthcare provider answers this, well, that dictates literally every single decision made over those 9 months.
Section 1. A person, not a chart.
Let's look at how this actually plays out in the real world through the perspective of licensed midwife Anissa Sartini, who runs Metroplex Midwifery down in Texas. Her core philosophy sounds completely obvious, right? Until you realize how rarely it happens in standard care. She emphasizes that everyone is completely different and deserves personalized care. It's about acknowledging a patient's unique body, their history, and their personality, all in the aim of keeping both parent and baby healthy and safe. So, Sartini doesn't start with a medical chart. She starts with the person. Think about a conventional hospital setting for a second. A laboring parent might see, 3 or 4 different nurses in a single shift, and the delivering physician might be someone they've literally never laid eyes on before. Decisions get made by consulting a chart. But Sartini argues that when you know a patient deeply before labor even begins, you pick up on the subtle cues, maybe a slight change in breathing or a quick moment of fear that a total stranger would completely miss.
And this personalization isn't just some warm, fuzzy philosophy. It has a real, measurable, clinical impact. A 2023 study on U.S. birth centers found something truly incredible. Midwives who actually took the time to understand their patients' histories, their fears, and their goals, they were significantly better at building their patients' confidence. And here's the real kicker. That confidence itself was associated with fewer complications. It's like the relationship is the intervention. Simply knowing and trusting your provider acts as a medical tool that reduces the need for physical interventions down the line.
This brings us to Section 2, physiological versus pathological care.
So how does this relational approach contrast with standard hospital protocols? Well, it boils down to 2 entirely different baseline assumptions. On one hand, you've got the midwifery model. This views pregnancy as a physiological default. In plain English, that means it's a natural process that should be supported. On the flip side, we have the obstetric model, which views pregnancy as a pathological default. This treats pregnancy as a condition to be managed, basically approaching every pregnancy as a potential emergency to prevent the absolute worst-case scenarios. And guys, these starting points matter immensely. If a provider views pregnancy as pathological, every prenatal appointment becomes a screening for what might go wrong, which, understandably, can breed a lot of anxiety. But if they view it as physiological, those same appointments become opportunities to support what's already going right, which builds up that protective confidence we just talked about.
Now, to be crystal clear here, having a physiological default definitely doesn't mean rejecting modern medicine. No way. Sartini points out that pregnancy is a natural process that, sure, sometimes needs assistance. She is absolutely not anti-medicine. She just believes the default setting should be absolute trust in the body's natural process. You keep the medical interventions right there, readily available, but you only use them when they are genuinely indicated.
Let's move to Section 3, what the data shows.
Okay, philosophy's great and all, but let's dive into the hard evidence. What happens when we put this physiological model into practice? A major 2023 review in the American Journal of Obstetrics and Gynecology looked at low-risk pregnancies in the U.S., and the outcomes were pretty striking. Midwifery care was associated with significantly lower rates of cesarean delivery, lower rates of episiotomies, and less epidural use. And at the exact same time, it showed much higher rates of spontaneous vaginal birth and successful breastfeeding initiation. The data is telling us a compelling story here. Slowing down and really leaning into relationship-centered care actually yields demonstrably better clinical outcomes for the vast majority of pregnancies.
And we have to look at the other side of the coin, because standard interventions aren't always just neutral. A landmark review in the Journal of Obstetric, Gynecologic, and Neonatal Nursing took a hard look at routine hospital practices. They found that interventions like continuous electronic fetal monitoring, artificially rupturing the amniotic membranes, and directed pushing, well, they can actually disrupt the body's normal physiological process without actually improving outcomes. In fact, the review noted something really important. These interventions, which are genuinely meant to help, can sometimes end up creating the very complications they were originally designed to prevent.
Which leads us to Section 4, the economics of obstetrics.
So if the data clearly favors the midwifery model for low-risk pregnancies, why on earth does standard American obstetrics rely so heavily on standard interventions? Take a look at this staggering disconnect. The World Health Organization identifies that a medically necessary cesarean section rate should hover right around 10 to 15%, but the United States average? It's a whopping 32%. That is more than double the WHO's recommendation. And to put that into perspective, the US actually spends more on maternity care per capita than any other developed nation, yet we rank the worst among peer countries in maternal mortality. There's just a massive disconnect here between the clinical evidence and standard medical practice.
Sartini makes a very candid structural argument to explain this gap. The reality is, healthcare isn't always driven purely by best practices. Decisions are frequently shaped by institutional incentives. For instance, a C-section simply generates significantly more hospital revenue than a vaginal birth. And beyond just revenue, providers are facing immense pressure from litigation fears and malpractice insurance penalties. Those factors strongly incentivize doctors to intervene early and often, almost as a defensive hedge against liability.
Because of these deep-rooted structural incentives, Sartini really encourages families to study the history of obstetrics. A lot of practices, like routine episiotomies, birthing in the lithotomy position where you're lying flat on your back, and continuous fetal monitoring, were introduced into routine care without strong evidence backing them up, and they stuck around long after research showed them to be unnecessary or sometimes even harmful for most normal births. Knowing this history, it doesn't make you a difficult patient at all. It makes you an empowered, informed patient who knows exactly why a specific procedure might be recommended to you.
Finally, Section 5, a different starting point.
Ultimately, understanding this whole philosophical divide lets us approach healthcare entirely differently. When you step outside that standardized checklist model, you unlock the phenomenal benefits of continuity of care. A realist review that explored this specific model found that when the exact same provider follows a patient through pregnancy, labor, and postpartum, it physically improves safety. That continuous relationship acts as a powerful protective factor, associated with reduced preterm birth rates and fewer emergency interventions. Why does it work so well? Because the provider knows what is truly abnormal for that specific person, rather than just relying on what looks abnormal on a generic chart.
So, as we wrap up this explainer, I want to leave you with one final, vital question to reflect on. Do you want a provider who treats your pregnancy as a condition to be managed or a process to be supported? Whether you end up choosing a hospital, a birth center, or a home birth, the evidence is pretty clear. You are not just a patient, you are a person. Understanding the incentives, knowing the data, and seeking out care that respects your unique physiology, that can fundamentally transform your entire healthcare experience.
I stopped trying to find a doctor who would listen, and I did this instead. For years, I was doing everything right. Eating clean, exercising, getting 8 hours of sleep, but I was still exhausted. I had constant brain fog, and my hormones felt completely out of whack. Every doctor told me my labs were normal, and it was probably just stress. I was about to give up until I found Holistic Health. It's a free AI wellness tool trained by functional medicine experts. I spent 5 minutes answering questions about everything: my symptoms, my sleep, my digestion, and it built me this. And this was the light bulb moment. It didn't just give me a list of problems, it connected the dots. It showed me how my gut health was likely impacting my hormones and how that was causing the fatigue and the brain fog. It even gave me a clear list of potential root causes, supplements to research, and even the specific lab tests to ask for. Its tip is secure. Over 77,000 people have used it, and it's 100% free to get your blueprint. If you feel like you're not being heard, start here. Understand your body first and then decide your next step.